Good afternoon, everyone. I also would like to thank the organizer of INASL for the kind invitation. Certainly honored to be here. And I was asked to talk about the predictors of outcome of liver transplant in the patients with ACLF. We have heard a lot of predictors in the afternoon, and I can assure you that when it comes to the prediction of ACLF post-transplant, there is not that many studies that came up with great predictors, so it's going to be a bit hopefully easier. These are my interests, complete. And as you heard from the previous speaker, ACLF is a syndrome that is characterized by acute decompensation of cirrhosis with severe inflammation and in addition to one or multiple organ failure, and there has been a number of consortium around the world that have come with different definition and grading, and it all boils on, in fact, to tallying the number of the severity and also the number of organ failure. And all this consortium has defined criteria to predict the outcome of ACLF, but this prediction is only in the setting of pre-liver transplantation and not post. We also know that mortality of ACLF patient in absence of transplantation is quite high compared to non-ACLF patient, and this mortality increases with the grade of ACLF, with patients being in grade 3 having higher mortality. It's also important to keep in mind that ACLF is a moving target, and it's very important to reassess the evolution of this patient very early on, at day 1, day 3, and day 7, because the prognosis of this patient may change. And this is a study from Canada, but there have also other studies that have shown that ACLF determination, grade determination at day 3, in these particular studies, about 40% of the patients have improved by 1 grade, half of the patient did not change, and definitively the mortality was correlated with the grading at day 3. For those patients that in fact make to transplant, the outcome of liver transplantation is generally good, is comparable to the non-ACLF patient, and there has been now a few studies, including a French multi-center study, as well as a very large UNO study that have shown the great outcome of this patient. And similarly, great outcome has also been reported utilizing live donor liver transplantation in the ACLF setting. The studies are mainly essentially from East, a Taiwan study, as well as a study from the group in Medanta that have shown really great outcome when it comes to transplanting this patient compared to non-ACLF. However, I put up this study, which is also a recently published study from the Delhi group, utilizing again live donor liver transplant for ACLF3 patient. And as you can see here, the outcome at short-term post-transplant in this particular study is not as robust or as excellent as the previous study that I mentioned. And with that, I want to make the point that majority of the ACLF studies in the setting of liver transplant unfortunately includes a heterogeneous population with various etiology of liver disease, different severity, and also huge selection bias when it comes to transplant. And for example, in this study, they have included patients that were under ventilation and were on pressors, which was not the case in the previous 2 studies with utilizing living donation. So what predictor do we have in terms of determining mortality of the ACLF patient? It's intuitive to think that MELD score or sodium MELD score would be a great indicator. However, we know, and there are now numerous studies, including this, again, large UNO study, that has shown that compared to the non-ACLF patient, the MELD score is not a good predictor for mortality, and in fact, even for lower MELD score patients below 35, the mortality of ACLF3 or other ACLF grade is not well represented by MELD. What are the other predictor of mortality? Again, from this large UNO study, you can see here in the multivariate analysis that donor risk index and being under mechanical ventilation and respiratory failure were the parameter that was associated with post-transplant mortality, and highlighting here that a difference of 10% survival was shown in terms of particularly mechanical ventilation for the patient post-transplantation. And in contrast, being able to transplant this patient early on, ideally before 30 days, some argue even within the first 7 days after their listing, it would be associated with a better outcome. Just highlighting a new study also that looked at donor risk index or marginal donors that previously were shown to be associated with a higher mortality, and it seems there is a change in the era of when these donors have been utilized, and in the most recent era from 2015 to 2019, this study using the donors with a DRI above 2, so higher index, the survival of ACLF3 patient was still quite good with these donors above 78%. What are the other predictors of post-transplant mortality? This table summarizes the studies that are in the literature, either single center or multi-center, European or UNO study, and you can see that majority of these studies have identified mechanical ventilation, respiratory failure, but also circulation support being on pressors, as well as donor age as parameters that is associated with higher mortality. The second study, which is a multi-center European study, has identified these four parameters: age above 53, lactate of 4, higher white blood count, and ARDS. And they have used these 4 parameters in a model called TAM model to predict the survival or mortality post-transplantation. And although this is a rather good score in these 76 patients in which were included in that study, the study or this score has not been validated in any other study outside Europe. Other predictors that are in favor of outcome post-liver transplant seems, again, as I mentioned, timing of liver transplantation, ideally less than 7 days. You can see here on the right-hand side, the graph shows a significant difference in terms of transplanting patient before 7 days as opposed to after 7 days, and also improvement of ACLF3 patient at the time of liver transplant. If they are improved to grade 2 or less, is definitively associated with a better outcome. So in terms of scoring, so far, besides the TAM study or the TAM score that I mentioned earlier, the only really good published score for predicting mortality after liver transplant is the Sundaram ACLF liver transplant mortality, aka SALT-M score. That uses this clinical and what they call readily available parameter that are the following: age above 50, BMI as a continuous variable, utilization of inotrope, non-1 or 2, respiratory failure, and diabetes. And this score has been validated in 15 centers in the US and 2 other centers in France, and as you can see here on the graph, it has a great discriminative ability than any other scores, including MELD or any of the variant of MELD with a AUC of 0.8. So just to summarize in terms of predicting ACLF post-liver transplant, what is very known and we are aware of is that the outcome of an ACLF patient without transplant is really poor, and post-transplant in selected patient, it could be similar to the non-ACLF patient recipient. MELD is definitively not reflecting the higher mortality and is not a predictor for this patient, and shorter wait list time improve post-transplant outcome. What we don't know or we are missing is really having studies that are prospective. Most of the studies, as I mentioned, are heterogeneous in their patient selection. And there is also subjectivity in terms of ACLF scoring that could potentially affect the outcome. And there is also a lot of other parameters, including the cost of managing this patient post-transplant in a hospital, readmission, ICU staying, as well as discussion regarding futility and utility of offering transplant to this patient. And what we need in the future is studies including machine learning to come up with better predictor of survival for ACLF patient post-transplant. And I do believe that these studies start slowly emerging, and hopefully we have better predictors in the future. With this, I want to thank you for your attention.